Today, we're going to review the clinical assessment of thyroid function, focusing on how thyroid hormones are produced, regulated, transported, and interpreted on laboratory testing. Accurate thyroid evaluation requires understanding each step of the hypothalamic pituitary thyroid axis and how various tests reflect different parts of the system. We'll also connect testing patterns to common clinical conditions like hypo and hyperthyroidism, autoimmune thyroid disease, and euthyroid sick syndrome. Let's begin with the physiologic actions of thyroid hormone. Thyroid hormone has widespread metabolic effects. It increases basal metabolic rate and enhances carbohydrate, lipid, and protein turnover. It also increases sensitivity to catecholamines, which is why hyperthyroidism can produce tachycardia or palpitations. Importantly, thyroid hormone is essential for normal growth and central nervous system development, particularly fetal brain maturation. When levels are off, we see multi-system symptoms that reflect this wide physiologic footprint. Here we expand into system-specific effects. In the cardiovascular system, for example, thyroid hormone has positive ionotropic and chronotropic effects, increasing both heart rate and cardiac output. In reproduction, adequate thyroid function is necessary for fertility and healthy pregnancy. In the central nervous system, thyroid hormone regulates synaptogenesis, myelination, and neuronal integration. And in the gut, it stimulates motility, which is why constipation is common in hypothyroidism and diarrhea in hyper. Thyrotropin releasing hormone, or TRH, is produced in the hypothalamus and released in a pulsatile circadian fashion. It travels via the hypothalamic pituitary portal system to stimulate TSH release from the anterior pituitary. TRH release is downregulated by circulating T4, contributing to the overall negative feedback system. Understanding TRH physiology is important when evaluating secondary or tertiary hypothyroidism, where the defect lies above the thyroid gland. TSH, thyroid stimulated hormone, is produced by the anterior pituitary and is the primary regulator of thyroid gland activity. It stimulates both synthesis and release of T3 and T4, and it promotes thyroid gland growth. TRH upregulates TSH, while T4 and T3 suppresses it through negative feedback. Because of this sensitivity, TSH is the single best initial test when evaluating thyroid function, except in rare pituitary or hypothalamic disorders. This slide outlines a full regulatory sequence. The hypothalamus secretes TRH, which triggers the pituitary to secrete TSH, which stimulates the thyroid to produce T3 and T4. TSH is the major modulator of thyroid gland activity, and even small shifts in T4 and T3 lead to measurable changes in TSH. This is why TSH is such a sensitive marker for primary thyroid dysfunction, but much less reliable when the problem is higher, pituitary or hypothalamic in origin. An anatomical review of the thyroid gland is helpful here because it's composed of follicles that are filled with colloid. This contains thyroglobulin, the protein backbone for thyroid hormone synthesis. The follicular epithelial cells produce T3 and T4. Between follicles are parafollicular or C cells, which secrete calcitonin. This basic anatomy is essential for understanding conditions like thyroiditis, multinodular goiter, and medullary thyroid carcinoma, which arises from C cells. Thyroid follicular cells have three main jobs. They concentrate and transport iodine, they synthesize and secrete thyroglobulin into colloid, and they remove thyroid hormone from thyroglobulin and secrete it into circulation. Each of these steps is tightly regulated by TSH, and disruptions at any point can lead to hypothyroidism or hyperthyroidism. Iodine transport and hormone cleavage are especially vulnerable in autoimmune thyroiditis and iodine deficient states. Now that we've reviewed the anatomy and functional framework of the thyroid gland, we'll move into the biochemical steps of thyroid hormone synthesis. These steps occur partially in the follicular cell and partially in the colloid, and they rely heavily on iodine availability, thyroglobulin structure, and the activity of thyroid peroxidase, which are all important targets in both physiology and disease. This slide highlights kind of some of our key steps of thyroid hormone synthesis. Iodine, which is absorbed inside the GI tract, is actively transported into thyroid cells via the sodium iodide symporter. Thyroid peroxidase, or TPO, which I think is here. Yep, right here. In the colloid, oxidizes iodide to iodine, which then binds tyrosine residues in onto thyroglobulin. Excess iodide is excreted in the urine. Because TPO is essential in this process, anti-TPO antibodies, as seen in Hashimoto's, can severely impair hormone synthesis. And looking here, I'll have this picture up actually, because I think this is more helpful as I kind of walk us through this. So once we're in the colloid area, iodine binds to tyrosine residues on thyroglobulin to form MIT and DIT. And we can actually see what those are here, monoiodotyrosine and diiodotyrosine. When one MIT and one DIT combine, they form T3 because there's three iodines. When two DITs combine, they form T4, which kind of would make sense logically. The natural ratio of T4 to T3 production is about 5.1 or 5 to 1, meaning the thyroid primarily releases T4 and then it's converted in the circulating tissue to T3. T3 conversion happens peripherally. This explains why T4 levels are typically much higher on lab testing, but T3 is the more biologically potent hormone. Looking at our structural relationship between the two thyroid hormones, T4 will contain four iodine atoms and acts largely as a prohormone, while T3 is the active high affinity hormone responsible for most of our metabolic effects from the thyroid gland. Their structure determines how they bind to receptors and transport proteins, and it also affects how they are converted or degraded. Understanding this structural foundation helps explain clinical conditions like T3 toxicosis or altered T4 to T3 conversion in systemic illness. Another key concept is that T4 and T3 are derived entirely from iodinated tyrosine residues. This is why iodine deficiency is a global cause of hypothyroidism and goiter. The structure also explains how specific medications, like amiodarone, can influence thyroid physiology since amiodarone contains iodine and alters peripheral conversion pathways. The chemical backbone of these hormones underlies nearly all thyroid disorders. Once T3 and T4 are released into circulation, the vast majority become protein bound. Only the free fraction is biologically active and able to enter target cells. Elevated T3 or T4 levels feed back to suppress TRH from the hypothalamus and TSH from the pituitary. When interpreting labs, it's critical to distinguish total hormone levels, which include bound hormone, from free hormone levels, which represent actual metabolic activity. We can see some quantitative facts here. About 98.5% of circulating thyroid hormone is T4, and only 1.5% is T3. Total hormone levels depend heavily on binding proteins, mainly TBG or thyroid binding globulin, as well as albumin and then transthyretin. However, regulation of the thyroid axis depends solely on the free fraction. This distinction is essential when we interpret our labs in pregnancy, liver disease, or patients taking exogenous hormones or medications that alter binding proteins. TBG, thyroxine binding globulin, is the major binding protein, otherwise known as thyroid binding globulin. This carries about 70% of both T3 and T4. TBPA and albumin also contribute but have lower affinity. Bound hormone serves as a thyroid hormone reservoir, which stabilizes our serum levels and allows for more of a gradual release of free hormone instead of just this massive like dump into the system. This buffering effect is why an acute change in synthesis or secretion does not necessarily immediately translate into symptoms. Binding proteins can help maintain equilibrium. If we have changes to TBG levels, that can dramatically alter total hormone levels without necessarily affecting free hormone levels. Several physiologic and pharmacologic factors influence TBG levels. High estrogen states, such as pregnancy or oral contraceptive use, raise TBG, which increases total T4 even when free T4 is normal. Conversely, androgens and advanced liver disease reduce TBG. Other medications, including NSAIDs, furosemide, and anticonvulsants, alter binding site competition, and these factors can produce normal free hormone levels despite abnormal total hormone levels, which is why free T4 and free T3 provide just better diagnostic perspective. When we come back, we'll talk more about the conversion of T4 to T3.